Now it's time, I think, for the first topic of today. It's a very interesting topic, and we receive a very great honor from one of the very well-known hepatologists. May I introduce Professor Ray Kim. Professor Ray Kim graduated medical school from Seoul National University in 1986 and entered the professional education at the University of Pennsylvania in Philadelphia, and a fellowship in Mayo School of Medicine in Minnesota in 1997 and 1998. He is now the Professor of Medicine and the Chief of the Division of Gastroenterology and Hepatology, Department of Medicine, Stanford University. He's also treasurer of the AASLD, which in charge of more than $100 million money in his control. He has a lot of publication, and it's very honor or privilege of us to have him today with us. He will give a talk about the screening of viral hepatitis and hepatocellular carcinoma, the why and the how. Professor Ray Kim, please.
I just thank thank you for the nice introduction. I also would like to thank the organizing committee and scientific committee for giving me this opportunity to address you this morning. ASLD doesn't have $100 million, just for clarification. It's much smaller than that, and I'm going to mention a little bit of that in my remark in the next hour. So my job is to talk about screening for viral hepatitis and HCC, the why and the how. And I thought about the topic, and my answer is yes and yes. And I could go home, but I'm going to talk some more about that. So everybody in this room should know about the health burden of chronic viral hepatitis. It starts with acute infection, moving to chronic infection, chronic hepatitis, leading to cirrhosis, liver cancer, that leads to death from cancer death or hepatic decompensation. The time spent for this course may span decades. Everyone should know in this room that hepatitis B is a globally prevalent disease. This is the latest analysis published in 2015, and compared to the previous data that was broken down into only 3 tiers, it has a more granularity to the data. And as we consider the region that we're in, there's still high prevalence area for hepatitis B, at least higher intermediate category. The China has changed colors, as you notice, so it has a little bit lower impact. If you look at hepatitis C, the picture remains about the same, that in this area, hepatitis is quite common. China is common, and the Southeast Asia in the moderate zone, 1.5 to 3.5%. So burden of viral hepatitis in this region, both B and C, is significant. And that has long-term impact, and this shows mortality from hepatocellular carcinoma. All this area is red, indicating that it has the highest risk of liver cancer death in the region. So I hope I made it abundantly clear that the burden related to viral hepatitis in terms of infection and its consequences is significant in this area. Given that, we need to think about screening for those diseases, and there is a published criteria how to go about screening. And the lists goes like, the condition being screened for is an important health problem. So it is clear that it is an important health problem, both viral hepatitis and HCC. The natural history of the condition is well understood. I think we are. There is a detectable early stage, so we want to detect people in chronic infection, chronic hepatitis state, rather than cirrhosis or HCC. Treatment at an earlier stage is more benefit than at a later stage. It is a lot easier to treat viral hepatitis than to treat liver cancer. A suitable test has been devised for the early stage hepatitis B, surface antigen, hepatitis C, HCV RNA, or antibody. They are very good tests, and the tests are clearly acceptable. This is not very relevant because we're not talking about repeated testing, but this becomes relevant for HCC. Adequate health service provision is made for the extra clinical workload resulting from screening. This is something that we need to talk about. As a specialist, when we consider screening, we focus on the patient and what happens to that individual patient. But this is a public health problem. We need to take a step back and look at the global issue about health service provisions. The risks, both physical and psychological, should be less than the benefit, and I think there's very little question about that with regard to viral hepatitis, and the cost should be balanced against benefits, and we're going to talk about that a little bit as well. So since I practice in the US, I'm going to present some US data and see if they can apply the same logic to other areas of the world. This slide shows mortality impact of HIV, hepatitis C, and hepatitis B in the US. Earlier on, HIV had a lot more mortality impact compared to viral hepatitis, but as of 2006, hepatitis C is higher in terms of mortality compared to HIV-related mortality. So compared to the higher publicity that HIV gets, viral hepatitis tends to get ignored in public health arena. That's an important problem. In order to assess what the impact of hepatitis C infection is, we undertook a recent study, and the study was led by a Thai postdoctoral scholar that's with me, and we looked at the National Health and Nutrition Examination Survey data, which is conducted by CDC. It represents the civilian, non-institutionalized US population. Hepatitis C data were available from 1988 to 1994 and 1999 to 2012. So in the data set, we had a large number of patients, over 100,000 participants. Half of them were tested for hepatitis C for a number of reasons. Out of those, about 1,000 people were positive for anti-HCV, 736 were positive for HCV RNA, and we divided these patients into three eras. First, early 90s, early 2000s, and late 2000s. So over two decades, a period of time. When we looked at the three eras with regard to how common HCV RNA was in the population, in era 1, 1.5% had HCV RNA positive. That decreased to 1.2% in the early 2000s. More recently, it went further down to 1%. Because NHANES is a population denominated, we can actually project to how many people that represents. 2.6 million American adults, 2.5 and 2.2 million Americans having hepatitis C infection as of 2012. So that is not very surprising. The main result that we saw was how common cirrhosis and advanced fibrosis is becoming among people with hepatitis C virus infection. So compared to era 1, using APRI as a score to detect cirrhosis, 6.6% in era 1, 7.6% in era 2, but that more than doubled in the last era 3, to 17%. Same trend was shown with FIB-4 score with advanced fibrosis, 8.6, 10.2 to 16%. So hepatitis C is relatively common in the US. The overall prevalence may be decreasing, but importantly, people with cirrhosis and advanced fibrosis is increasing. Another aspect of the data that is very relevant for the screening purpose is that advanced fibrosis was as common in people who are not aware of infection, hepatitis C infection, as they were in people who knew about their hepatitis C infection. So this slide shows the probability of advanced fibrosis based on FIB-4 score. People who had known about their hepatitis C before they participated in the NHANES survey, 15% had advanced fibrosis. There were people who did not know about their hepatitis C. They came to the survey, they were tested for hepatitis C and were surprised to discover that they had hepatitis C. 22% of those individuals had advanced fibrosis. indicating that most people with hepatitis C infection is asymptomatic and they are not discovered until they are screened purposely for the infection. So the fact that hepatitis C is common, advanced fibrosis and cirrhosis is increasing, and people who are not purposely screened have advanced fibrosis all converge into a concept that there needs to be screening for hepatitis C. And this slide shows the screening policy for hepatitis C in the United States. And this is based on NHANES data, again, for HCV prevalence. If you look at the prevalence by the birth cohort, people who are born in 1945 to 1965 have the highest prevalence. This is a result of two different NHANES survey. Both data sets suggested that people who are born around 1950 and 1960, their anti-HCV positive prevalence was 4 to 5%. So this is the population segment that can be identified to carry a high burden of hepatitis C, and the government officials recognize that that's a target that can be used to screen for hepatitis C. So that's called birth cohort screening, and it is recommended that people should do one-time testing in the birth cohort who are born between 1945 and 1965. And that is in addition to risk-based screening, which is that people who have underlying risk factor or high risk for infection, such as injection drug use or transfusion recipients before hepatitis C testing became available, they also need to be tested. So in the US, hepatitis C screening has official policy for early detection and treatment. The other coin of screening is that if you just screen in and there is nothing to be done after screening, that it makes no sense to screen patients for disease. So this slide shows the impact of sustained virological response for hepatitis C and what their impact is in long-term outcome. This is a paper that came out of the Netherlands where they looked at 530 patients with advanced fibrosis and cirrhosis, and they were followed for a median of 8.4 years. And they compared what happened to them with regard to patients who achieved SVR versus those who did not achieve SVR. When they looked at all-cause mortality, people who did not respond to treatment, their 10-year occurrence rate was 26% compared to 9% who achieved SVR. If you just look at the liver-related mortality or liver transplant, the gap is even wider. 27% had either death or liver transplant when they did not respond to antiviral treatment, only 2% in people who are cured of hepatitis C. Cancer that we're talking about, HCC, 22% in non-responders, 5% in responders. It's a fourfold difference. So SVR had a quarter, has a 1/4 of the risk of HCC when you achieve SVR. Liver failure, similarly high difference, 30% versus 2%. So clearly, sustained virological response has a long-term benefit when it is given, especially early in patients with hepatitis C. This is a recent meta-analysis looking at the impact of SVR on incidence of HCC. They looked at 12 studies, and these are the studies that they looked at, and compared people who had SVR versus non-responders, and you're looking at a significant number, a substantial number of people who are compared. When they analyzed the hazard ratio of developing HCC between sustained responders versus non-responders, the summary statistic was 0.24, about 25% or 1 out of 4 risk reduction in people who achieve SVR compared to non-responders. So this is consistent with the prior data from the Netherlands that cancer risk went down by 1/4 in people with a sustained virological response. So 1.5% versus 6.2% with regard to cancer. They also looked at advanced fibrotic patients, and the risk was the same, so 0.23 of risk reduction. So it means that it doesn't matter when the treatment is applied. People who had advanced fibrosis, as achieving sustained virological response had similar benefit as people who achieved SVR when the fibrosis stage was earlier. One caution for this is that these are observational data from interferon era, and there's an overlap between people who benefit from treatment as well as people who can achieve SVR. So that's something to think about. But the bottom line of the story is that treatment leads to long-term benefit. To screen, diagnose, treatment, and long-term benefit, that's a sequence that is apparent for the benefit of screening. So before CDC and USPSTF implemented cohort screening strategies, there were multiple analyses looking at the benefit of birth cohort screening. So this is one such study that looked at the projected reduction in incidence among Americans born between 1946 and 1970, and analysis projected that there will be 77,000 fewer deaths related to hepatitis C if you screen this whole population with regard to the birth cohort. We would reduce nearly 10,000 liver transplant, 46,000 liver cancers, and 84,000 hepatic decompensation events by screening. And that, again, is a result of a sequence of events: screening to diagnosis, treatment, and long-term outcome. So the goal of the screening, as you think about this, is to find out who has the infection. So you go to the undiagnosed hepatitis C population, and you want to achieve reduced burden as a result of multiple steps. But this doesn't happen in a vacuum. The screen is not the means. There are multiple steps that we need to think about. From undiagnosed hepatitis C, we need to have a screening policy. It is probably impossible to screen everyone in the population for hepatitis C, so we need to have a selection criteria. In the US, it became the birth cohort. It may be different in Thailand, it may be different in Vietnam or China. Once the screening policy is decided, then you need to have some sort of a support from healthcare system. If you go out and screen a person for hepatitis B, hepatitis C, and there is no way for the patient to go into the healthcare system to be evaluated and then treated, then there's no point of screening patients for those conditions. Once you have that, then you need to have sufficient manpower and expertise. Viral hepatitis management tends to be complicated. You need to have enough people who know what to do and enough knowledge level in those people who see the patients. And then once you have that, you need to have rational treatment guidelines. Hepatitis C is somewhat complicated, hepatitis B is complicated. You need to have a uniform way of treating patients, otherwise this will create chaos. And only then you go to the next phase where we see patients. Then we need to make sure that patient accept treatment, there's funding for the antiviral treatment, and the patient adheres to treatment. So when you talk about screening, we don't necessarily think about all these necessary steps that need to occur for the screening to be effective, but screening is a public health concept, and in order to achieve what we want to achieve, we need to think explicitly what is needed subsequent to screen so that we can achieve these benefits. I'm going to then turn to surveillance for hepatocellular carcinoma. Clearly, it is important to early diagnose hepatocellular carcinoma early, and that's because in patients with large HCCs, the prognosis is dismal, whereas smaller lesions can be potentially curable. Surveillance means repeated application of screening tests. Screening tests is a one-time thing. Surveillance is a multiple repeated application in high-risk subjects. It must improve overall survival, and that is related to a couple of biases that you need to think about. There's one lead time bias. If you put a patient into surveillance, you may discover cancers early, but even if it doesn't do anything because you diagnose patients earlier, you may have the appearance of the patient surviving longer. Length bias means that there may be biological difference in the kind of cancers that are subject to discovery from screening that is different than cancers that are not discovered by screening, and that again give you a bias that surveillance may be beneficial, but you need to overcome those things and look at the overall survival to demonstrate that surveillance is beneficial for our patients. The strongest data that HCC surveillance improves mortality comes from this study conducted in China. It was a cluster randomized trial, what the epidemiologists call, and they randomized people to receive ultrasound and alpha-fetoprotein every 6 months versus no intervention up to 5 years. And they had a large number of patients that are candidates for this surveillance, either surface antigen positive or history of chronic hepatitis. This is the bottom line result. When they looked at overall mortality as they were supposed to, surveillance group has significantly lower mortality at 83 deaths per 100,000 per year, compared to the usual care, which was significantly higher. And the risk reduction was 37%. So by applying surveillance, you were able to reduce the risk of death by more than a third. So this is the strongest data. So there is very little question in many people's mind that surveillance is a good thing, but the reason why there's controversy, if there is, about surveillance is because it is difficult to calculate or estimate the value of doing surveillance. So in order to have a benefit from hepatocellular carcinoma surveillance, you need to deploy resources to discover those patients and whether the money spent to do tests is worth the effort. So what is value in healthcare with regard to HCC surveillance was the question, and the value can be summarized as outcomes divided by cost. So I'm going to talk a little bit about cost effectiveness, and the metric to measure value in health is called incremental cost effectiveness ratio, or ICER. And it's a ratio between the cost differential divided by effectiveness or outcomes differential. With regard to HCC surveillance, the incremental cost effectiveness ratio is measured by the cost that is needed with surveillance minus cost that will incur without surveillance divided by some sort of a measure of outcome. It can be survival following surveillance minus survival without surveillance. So the end result of this calculation is how much money do you need to spend to save one life as a result of HCC surveillance. That's the calculation that needs to be done. But the calculation itself is pretty complex. So if you just think about what is the cost associated with surveillance, there are many things. Cost of surveillance testing, the ultrasound, alpha-fetoprotein, whatever it may be. And once you have positive surveillance, you need to do CT, MRI, whatever it is. And then there is investigation of false positive tests. If they are false positive, you incur unnecessary cost. There may be complications if you need to do a liver biopsy or do a CT scan or MRI with contrast, you may cause problems. Then cost of treatment for early HCC, you need to treat more patients than without surveillance. And this is something that need to be thought about a little bit more. If you discover and cure cancer early, and more patients will develop hepatic decompensation because you're prolonging survival of cirrhotic patients. So that's another aspect of cost that you need to think about. How about cost without surveillance? That will be cost of treatment for late-stage HCC. The survival benefit of surveillance is that you get fewer cancer deaths, you avoid poor quality of life from advanced HCC. However, there will be more deaths and poor quality of life from hepatic decompensation because it's what is called competing risk. If you don't do surveillance, there will be more deaths from advanced HCC and poor quality of life from advanced HCC. So in concept, the ICER of calculating what is the value of surveillance is pretty simple, but in reality, in order to do this calculation, you need all these things factored into the estimation. So this is an early study that just did that. It looked at the cost effectiveness of HCC surveillance, 1996 data. It was a mathematical model with the following conditions. They looked at child Pew score 8 patients. They used ultrasound and alpha-fetoprotein versus no surveillance. And the treatment of choice for HCC was resection, and they had no liver transplant in the calculation. Because of the complexity of assumptions and calculation that need to be made, they had best case scenario, intermediate case scenario, and worst case scenarios. And then in the study, they found out that important determinants of the value of HCC surveillance were the age of the patient, how common HCC was going to occur, and what is the survival after resection. This is the data, part of the data that they showed. In the best case scenario, they said sensitivity of screening test would be 85%, and the 5-year survival of CTPA score at 8 patients will be 85%. HCC instance, when you have 4% high-risk patients, then ICER was lower than when the instance was higher. So if you think about it, as you discover more patients, it becomes more cost-effective to screening for HCC. If you have older patients, it's less cost-effective. If the patients survive less after surgery, then it becomes less cost-effective. So it makes all sense. The point of this calculation is be able to say at what level do we feel comfortable that, okay, this is cost-effective. And in the US, that criterion is $50,000, meaning the society seems to feel comfortable that they will spend $50,000 to give a patient 1 year of healthy life, okay? A person's life, 1 year of healthy life in the US seems to be worth about $50,000. And that is a very tricky metric, and it will be dependent on many different things in different societies. But in the US, it happens to be 50. So when we draw the line, then most of the subgroups seem to satisfy the criteria for acceptable cost effectiveness. That's base case scenario. And this, by the way, is why the ASLD HCC surveillance guideline picked 1.5% as a cutoff to screen for HCC based on this analysis. However, when you look at their intermediate case scenario, the story changes pretty rapidly. Notice the y-axis is significantly higher in this figure than the last. And if you drew the $50,000 mark here, there are many bars that are above 50,000. So the same 1.5% HCC incidence, if you're in an intermediate case scenario where sensitivity test is lower at 65% instead of 80%, and the 5-year survival of your patient is only 75%, then 1.5% instance cirrhotics, it becomes not cost effective. It becomes very expensive to surveillance those patients even at 1.5%. Even at 4%, it becomes outside the cost-effective criteria. So most of these bars, with a little bit of change in the assumption, they become not cost-effective. So that's something that people don't talk about, but it needs to be considered explicitly. So based on this limited data, ASLD has recommended the best they can. In cirrhotic patients, again, 1.5% or higher risk of HCC, included hepatitis B, hepatitis C, and PBC cirrhotic patients. Alpha and antitrypsin deficiency and hemochromatosis are probably indicated, and maybe all other cirrhosis need to be included in the surveillance. Hepatitis B patients, the criteria is lower at 0.2% in non-cirrhotics, and these are well-known criteria: Asian male over 40, Asian female over 50, African immigrants over 20 years of age, family history of HCC, and other markers of high risk of HCC are used to select HCC surveillance candidates. I just want to showcase some of the work that we did to highlight that these sort of a rule of thumb criteria is quite crude in addition to the complexity of cost effectiveness analysis. This is an analysis that we did based on the US transplant waitlist patients. We looked at the instance of de novo HCC. Out of 35,000 registrants, about 2,000 developed new HCCs. When we looked at the annual instance of HCC by diagnosis, and this is again 1.5% mark, alcohol, hepatitis C, and hepatitis B, NASH, all were above 1.5% criteria, but PBC, PSC, autoimmune hepatitis, Wilson's disease were way lower than 1.5%, and alpha-1 antitrypsin deficiency and hemochromatosis seem to be above that. So in this case, it seems clear that one-size-fits-all sort of attitude for HCC surveillance may not work because the risk of patients are all different. And using the model, we can calculate what the risk will be, and the variables in the model based on the data for age, diabetes, race, etiology, viral versus others, gender, CTP score, and you can put it all together and come up with a score and be more accurate about who is the candidate for HCC surveillance. This is an example of how a predictive model may be useful in determining HCC surveillance candidates. In this part of the world where hepatitis B is more common, there are a number of hepatitis B specific HCC risk predictors, including one that Dr. Wong in the audience published that shows specifically what is the risk of HCC risk in terms of selecting HCC surveillance. So with what is more controversial? This is a recent review looking at what mode of surveillance tools need to be used. And if you look at the upper part of the corner that I will blow up here, ASLD and EASL criteria mainly use ultrasound without alpha-fetoprotein, 6 monthly intervals. If you detect nodule based on the study size of the nodule, you'd repeat or do more testing. But if you look at the lower part of the slide, Apostle and China, you incorporate alpha-fetoprotein and ultrasound every 6 months, and then the subsequent strategy becomes different with regard to the alpha-fetoprotein and the size of the nodule. If you go to Japan, on the right lower hand, it becomes very, very complicated. It depends on the risk with regard to the interval, what tools to use, and so forth. I'm going to make an argument in our recent study that the exact tool of what you use to do surveillance may not matter that much. This is a study that we did using simulation modeling technique. We looked at 50-year-old people followed for 15 years. These were all compensated cirrhotic patients with MEL score of 8, and over time their MEL score would go up and they will die of hepatic decompensation. We used the HCC instance of 3% per year in this cirrhotic population, 70% sensitivity, and we used liver transplant to prevent mortality from HCC or hepatic decompensation, unlike the Sarrazin study that was published 2 decades ago. This is our main result. Mortality per 1,000 patients. Without surveillance, about 740 people would die over a 15-year period. If you did surveillance followed by radiofrequency ablation, it becomes less, surgery even less, and liver transplant was the best strategy to follow surveillance because it reduced the risk of mortality by about 10%. We were never able to achieve 37% risk reduction that the Zhang paper showed in the randomized clinical trial. But the point that may be relevant here is that in addition to this impact being pretty small with all these efforts, but we found very little impact on the exact screening test sensitivity. So the moral of the story is that it doesn't matter what tool you use. It is important for you to do the test to pick up patients with liver cancer. It is kind of a futile exercise to fight against alpha-fetoprotein versus ultrasound or combination or whatever else. Do something, and that will make a difference. The other part of the data that we looked at is the importance of hepatic decompensation and what to do, and that's effect on hepatocellular carcinoma surveillance. So here are the 4 bars: no surveillance, RFA following surveillance, surgery, and liver transplant. This is our base case scenario where 40% of people with who would die of hepatic decompensation will receive liver transplant, 70% without surveillance would die, 64% with liver transplant would die. So there's a 10% reduction. But if you didn't have liver transplant for hepatic decompensation, look what happens. Virtually everybody dies of hepatic decompensation. So HCC surveillance in the absence of liver transplant has limited utility. And that is shown here. However, when you fixed hepatic decompensation with no progression, this will be a situation where a viral hepatitis patient, cirrhotic or treated, their disease doesn't progress, then it makes a lot of sense to surveillance those patients because RFA, surgery, or liver transplant doesn't matter. There's a significant benefit in terms of mortality reduction. If you're familiar with the concept number needed to treat, in the absence of liver transplant, the number needed to treat to save one patient with surveillance becomes huge. Again, indicating that depending on the healthcare setting that you have, if you have limited access to liver transplantation and the patient continues to have liver disease progression leading to hepatic decompensation, then doing surveillance in those patients doesn't make much sense as opposed to situations where you have all the tools available to help the patient. So let's take a step back and look at the HCC surveillance. There are a few factors that affect our medical and value decision. It's a patient, their demographics, their comorbidity profile, the disease itself. What is the HCC instance? What is the prospect of hepatic decompensation? We need to take that into account. And the healthcare factors. Is liver transplant and other complicated, sophisticated treatment modality available or not? That's important. And what are the competing programs? Governments and healthcare programs only have limited resources. So there are other competing programs that we need to make sense to the policymakers that this is an important high priority project. They need to allocate resources to help our patients. So in summary, screening for viral hepatitis is a public health decision. It has a large impact in this Southeast Asian region. We know about the benefits of treatment. However, we need to pay attention to healthcare infrastructure for evaluation, monitoring, and treatment of patients who will be discovered through screening. And therefore, it is important for us to engage public health and primary care focused individuals. We don't, as a specialist, we don't go out into the community and screen and make a big impact. Our role is to advise public health officials and primary care doctors that screening is important. With regard to surveillance for HCC, we talked about medical versus value decision, and there are many variables that affect not only value decisions, but also medical decisions that affect outcomes and cost of surveillance. There are policies that are specific to country or healthcare systems that will be dependent on the objective assessment of benefits and losses, and then based on best available data, as we discussed with regard to the risk prediction models. Thank you very much for your attention.
We may have time for one question. Professor Kim, do you also surveillance HCC in the patient with isolated B-core IgG positive? S antigen negative, only B-core IgG positive?
I personally don't, and the guideline doesn't recommend it. And so surface antigen negative, core positive, and surface antibody negative patients. So those are typically not included in surveillance. I don't know if things are different in this part of the world, but the risk of HCC in those individuals is probably much lower than any of the criteria, whether that is 1.5% or 0.2%. So at the public policy level, it will be pretty difficult to advocate that we need to surveillance those patients. Thank you.
Thank you very much. Thank you, please.
Thank you, Ray. Very interesting talk, and I'm kind of surprised liver transplant didn't make an impact on mortality in these cases. How do you explain that? And based on your concept that surveillance doesn't really make a lot of difference, the types of surveillance, shouldn't we be more active in treatment? and prophylax against HCC. For instance, treating more patients with viral hepatitis, one approach, and then there are many other agents that shows activity, like coffee, for instance. You should advocate more coffee drinking, and maybe we need to do some clinical trials on this. What are your thoughts on that?
Thank you, Professor Lim. It's so nice of you to link the two topics together that I wasn't able to do. HCC, viral hepatitis screening and HCC surveillance is linked, and that is gets to the fact that it is much wiser for us as a society to treat viral hepatitis than to wait until the patient becomes cirrhotic and then do surveillance. So there's no question that prevention is a lot better than treatment. With regard to the project that we did, why the difference seems to be small, that is because we looked at the whole population of cirrhotics, and not all of them develop HCC. So if you just looked at the people who develop HCC, the difference between liver transplant and no surveillance becomes much larger, and it becomes more tactile as to what we feel in our practice. And the non-pharmacological treatment for or strategies to reduce HCC, I think we need more studies. I mean, the coffee has been publicized pretty widely that is good for the liver, and I drink coffee, but I don't actively recommend for my patients to drink coffee because I'm not convinced that it has a strong enough evidence that it is to be advocated. Thank you.